Welcome to This Week in Family Medicine. This week we're covering 9 notable papers spanning diagnostic restraint and overtreatment in primary care, prevention gaps in the populations we serve least well, and new evidence on integrating and scaling care for chronic disease and mental health. Let's dive in. We'll start with the theme of doing less and doing it deliberately. JAMA Internal Medicine published a clinical review of shoulder pain in primary care by Haas and colleagues, and its central message is one of restraint. Shoulder pain is the third most common musculoskeletal presentation we see, and the review argues for abandoning the tangle of overlapping labels: impingement syndrome, rotator cuff tendinopathy, subacromial bursitis, in favor of the single-term subacromial pain, because those diagnostic labels are inconsistently defined and rarely change what we do. Once you have excluded the rare serious causes through history and examination, infection, malignancy, fracture, dislocation, referred pain, systemic inflammatory disease. First-line management is essentially the same regardless of the label. Explain the favorable natural history, offer symptom relief and activity modification, and watch and wait. Early imaging is explicitly not indicated without significant trauma or red flags, because structural abnormalities on imaging often do not correlate with symptoms and set patients on a path to overdiagnosis and overtreatment. And the authors describe the evidence that subacromial pain does not benefit from surgery as high certainty. That is a clear license to reassure rather than refer. A very different study makes a related point about testing. In the Scandinavian Journal of Primary Healthcare, Lykkegaard and colleagues used Danish registers covering more than 860,000 out-of-hours consultations to ask whether being seen by a general practitioner who reaches often for C-reactive protein point-of-care testing changes a patient's later health-seeking behavior. Testing rose from 12% of consultations in 2014 to 19% in 2017, and patients seen by a doctor with at least double the average testing propensity were slightly but significantly more likely to come back to out-of-hours care over the following years. The effect size is small, a hazard ratio just under 1.04, and the authors are careful to say this could reflect the test itself, correlated doctor characteristics, or both. But it is a signal worth holding on to. A test ordered for reassurance may quietly teach patients that reassurance requires a test. Our second theme is prevention gaps and where they concentrate. Also in JAMA Internal Medicine, Roldan and colleagues analyzed National Health and Nutrition Examination Survey data from 2017 to 2023 to estimate serologic immunity to hepatitis A and B across United States adults. Just under 40% of adults had evidence of hepatitis A immunity, and only about 27% had hepatitis B immunity, with roughly a quarter showing vaccine-derived protection. The gaps were worst precisely where the stakes are highest. Among people with metabolic dysfunction and alcohol-related liver disease, only about a quarter of patients were immune to hepatitis A, and among people with chronic kidney disease, only 14% had vaccine-derived hepatitis B immunity. Older adults were far less likely to be protected than younger ones. The practical implication is to make hepatitis A and B serology and catch-up vaccination a routine part of chronic liver disease, chronic kidney disease, diabetes, and immunosuppression care rather than an afterthought. PLOS Medicine extends the equity theme with a population-based analysis by you and colleagues of mortality among adults with intellectual disability in England. Among more than 1,300 adults with severe or profound intellectual disability, the median age at death was 57.9 years, compared with 65 for those with mild or moderate intellectual disability and 82 in the general population. An adjusted difference of about 7 years even after accounting for other factors. 2/5 of those deaths, 39.5%, met the definition of avoidable, meaning death before 75, from a preventable or treatable cause, amounting to more than 15,000 years of life lost. Dysphagia was present in 63% and epilepsy in 36%, which points to concrete targets: aspiration risk, seizure management, and vision. Alongside these, the New England Journal of Medicine published a review by Shelley and colleagues on tobacco cessation in low- and middle-income countries, where more than 80% of the world's 1.3 billion tobacco users live, and where only 31 countries meet the World Health Organization best practice standard of funded behavioral support plus pharmacotherapy. Using case studies from India and Vietnam, the authors make the case for systematic screening paired with brief clinician advice, quit lines and digital supports, and the Ask Advise Connect model, combined with essential medicines pharmacotherapy such as cytosine and nicotine replacement. The Ask Advise Connect framework is a reminder that our job is not to deliver the whole intervention, but to reliably make the connection. The third theme is integration, bolting care for one condition onto an existing service that patients already attend. The Lancet Global Health reports the Intercare trial by Mozepile and colleagues, a pair-matched cluster randomized trial across 14 HIV clinics in Botswana, enrolling more than 4,600 adults with both HIV and hypertension. Clinics randomized to integrated care received provider training, coaching, community treatment partners, and use of the National Electronic Health Record to support diagnosis and electronic prescribing during routine HIV visits. At 12 months, blood pressure control among patients on antihypertensives was 67% in the intervention clinics versus 52% under standard care, about a 30% relative improvement, and electronic antihypertensive prescribing rose from 11% of encounters to 40%. Critically, viral suppression stayed above 98% in both arms, and serious adverse events were rare and no different, so adding hypertension care did not dilute HIV outcomes. In the same spirit of scalability, PLOS Medicine published the Respond randomized trial by Roos and colleagues, testing a remotely delivered stepped care program for Polish migrant workers in the Netherlands with elevated psychological distress. 218 participants were randomized to care as usual or to guided online self-help followed, if distress persisted, by problem-solving therapy over video conference, both delivered by non-professional helpers. At the 2-month follow-up, combined anxiety and depression scores were about 6.5 points lower in the intervention group, a moderate effect, with benefit already visible after the low-intensity first step. Notably, close to 90% of participants who completed the first step still met criteria to progress to the second, so the low-intensity step alone was rarely sufficient. Generalizability is limited. Most participants were women who had lived in the Netherlands for years. Finally, 2 infection papers worth knowing about. Science Translational Medicine reports a randomized placebo-controlled trial by Shankar Hari and colleagues giving a single dose of 13-valent pneumococcal conjugate vaccine to 214 sepsis survivors at intensive care discharge on the hypothesis that vaccination might accelerate immune recovery. It did not. Over a year of follow-up, there were more infection-related rehospitalizations or deaths in the vaccine arm than in the placebo arm, with a hazard ratio of 1.23 and a confidence interval crossing 1, so no benefit, and if anything, a signal in the wrong direction, with higher reinfection rates and earlier antibiotic prescriptions in primary care. Antibody responses were highly variable between serotypes and individuals. There were no vaccine-related serious adverse events, but this is a negative trial. Timing vaccination to ICU discharge in sepsis survivors is not supported. And Nature Reviews Disease Primers published a comprehensive primer on methicillin-resistant Staphylococcus aureus, a useful refresher on the spectrum from uncomplicated skin and soft tissue infection to bacteremia and osteomyelitis, and on the fact that decolonization and screening strategies vary in effectiveness depending on local prevalence. If you only have time for one paper this week, make it the JAMA Internal Medicine Review on shoulder pain. It addresses one of the most common presentations in general practice and gives you explicit, high-certainty permission to skip the imaging and the surgical referral in the great majority of patients. Here are the key takeaways from this week in family medicine. First, for non-traumatic shoulder pain without red flags, education, symptom relief, and watchful waiting are the treatment, and imaging is more likely to harm than help. Second, Be aware that a habit of point-of-care testing may correlate with patients returning more often, a small effect, but a reason to test with a question in mind. Third, check and complete hepatitis A and B vaccination in patients with liver disease, kidney disease, diabetes, and immunosuppression, where susceptibility remains very high. Fourth, patients with severe or profound intellectual disability are dying more than 20 years early, with 2/5 of deaths avoidable. Screen actively for dysphagia, epilepsy, and vision problems. Fifth, integrating chronic disease care into an existing visit works, as blood pressure control improves substantially in Botswana's HIV clinics without harming HIV outcomes, and stepped mental health care delivered remotely by non-professionals can reach populations that avoid formal services. And finally, pneumococcal vaccination at intensive care discharge did not reduce reinfection or death in sepsis survivors. That's your roundup for This Week in Family Medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.